These are serious times. I'm Jens Chapman, 6 a.m. here in Seattle and 8 a.m. in Texas, and this is a great honor for me to get to work with my favorite colleagues outside of SNI here, and that's my friends and colleagues at TBI. So good morning to you, and it's historic and incredible for us to get together during these harsh times. I'm going to take my mask off. I just did this for effect to show how serious times are. And obviously all of our lives and practices and our patients' lives and well-beings are significantly usurped, but we all need to stick together and work together in these times to try to figure out best ways of dealing with things. Want to really thank Dr. Ziegler and Dr. Geyer for the inspiration and the idea of putting this together. And I hope that we'll obviously all work together also through the various tech challenges that we have. We're very proud of our fellows. Maybe we can put on the head slide for that, Lee or Alexis, for our fellows. And I'll ask them to introduce themselves. And we're going to take turns here at the stand, and we'll wipe off the remote control every single day. We have thought that we would, as an inaugural topic, talk about bone density and what it really means in clinical practice. To make it really tangible, we've selected 3 cases of mine where failures occurred. So nobody else's cases but mine, so you can see my complications firsthand. And we can see what it really means to try to predict bone density based on conventional things. So 3 articles will be presented. The ground rules for us were to do it really fast and short and critical. So each case will be followed by one relevant article to a certain topic area. And then I hope that we can have an interactive discussion with our friends in Plano, Texas. And the rules for the PowerPoints that you'll see are to be very succinct. So it follows something that we call a pecha kucha format, so it has to be very tight, under 7 minutes, and I'll sit there with my timer to make sure that they stay on time. And hopefully we'll have time for about 5 to 7 minutes of discussion. Each block of these 3 blocks that we'll have will be about 20 minutes. In order not to waste much more time, I was going to ask Dr. Heyman to do the first talk, but he's still not here. So I'm going to ask Dr. Cliff Pierre to take the lead, and each fellow I'll ask to briefly introduce themselves and where they're from originally. And this is Dr. Cliff Pierre. Thank you, Cliff. Thank you.
Good morning. My name is Clifford Pierre. I am one of the fellows here at the Swedish Neuroscience Institute and Seattle Science Foundation. I'm originally from Brooklyn, New York. I did medical school at the University of Rochester and started neurosurgery training there. So I'd be happy to get started with the first journal that we had chosen for today, and then thereafter, hopefully we can address one of the cases that Dr. Chapman had noted. So again, the topic would be understanding the meaning and practical use of bone density test and screening for spine reconstruction surgery. So the first journal that we have here is by Dr. Gupta et al. With Dr. Hirschman's group from the Massachusetts General Hospital. And what they sought to do was investigate the use of DEXA scans in adult spinal deformity patients. And so one of the things that we hope to address with the goals of the article would be to understand the reliability of such modality and further understand any limitations. Just a brief background, as Dr. Chapman said, we're going to go pretty fast with this, is one of the things we understand with osteoporosis being a skeletal disease condition that has grown prevalence in Americans. Right now it's stated that about over 10 million Americans suffer from this condition. And concurrently, we also see that this has been an increase in surgical comorbidity. So for specifically for adult spinal deformity patients, one of the things that we want to note is it's important if we're going to consider surgical treatments, more specifically any instrumentation to assess for this disease preoperatively, because it might change the surgical plan or such as what type of instrumentation that we do, let alone if we need to do any hardware augmentation. And so that's important to assess for any osteoporosis. And this is typically done right now. The gold standard is dual energy X-ray absorptometry, DEXA scans, measuring the bone mineral density, measuring T-scores, which is a comparison of the standard deviations of a patient's bone mineral density with a comparison group of what is considered a normal, healthy, young 30-year-old adult in the normal population. WHO criteria, the World Health Organization has created this criteria for which a patient, if their T-score is less than 2.5, diagnosed with osteoporosis. In this slide, we show the most common sites being the lumbar spine as well as the hip. In this case, the paper is focusing on trying to see if the use of DEXA scans in the forearm can be just as reliable as the other sites that are done. Some of the highlights of the study, again, clinical purposes to understand the value of DEXA scans on the forearms to assess for low bone mineral density. They did it at a single center. 286 patients met their criteria for having adult spinal deformity and osteoporosis. Primary outcomes was to measure the T-scores across the various anatomic locations and diagnose low bone mineral density as such. One of the first tables in the study just gives an overview of the 286 patients and the locations that the DEXA scans were measured at. And here we see patients that had only forearm or hip scans only were about 68%. Those that had combined was about 25%. And then for those that had all three sites measured was 7%. And in Table 2, what they did was a subset of the group being 85 patients who had multiple anatomic sites. They noted just the demographics for such, and about 90% of those patients were females, and we'll discuss that further. Table 3 being where most of the money action of the article is, it again just shows a comparison of the DEXA scan, the T-scores for the forearm and the hip. And one thing we note here, the DEXA scans for the forearm had a wider range for the T-scores. And what they were able to understand after doing some statistical analyses, there was no statistical difference of doing the DEXA scans in the forearm and the hip. And so what they were able to show was that the forearm had more sensitivity than the hip in its ability to detect osteoporosis or osteopenia. And it did so about 41% of the time. One of the second figures in the paper, what they did was provide a comparison of how often clinicians would hypothetically have an incorrect diagnosis if using the hip scan alone. And one thing we see here on the bar chart is that if they did the hip scan alone, about 6% of the patients had normal bone density. And when they included the forearm, they would be diagnosed with either osteoporosis or osteopenia. And so about 6% of the patients were misdiagnosed initially. And the last figure of the article, again, discussed the consistency of making such diagnosis and how often these can be done with the forearm of scans. And so one thing that they were able to note, again, misdiagnosis was done in over 17% of the patients. So that's 1 in 6 patients. If you had did a forearm scan, you'd be able to detect the diagnosis of osteoporosis. But when you did not, you missed it. So is DEXA the gold standard or not? So some of the advantages of DEXA scans generally is, again, it's high reproducibility, it's non-invasive, it has minimal radiation exposure, it's about 1/10 of what a standard chest x-ray is. Some of the pitfalls, again, is the multiple anatomic sites as well as multiple pathology. Some artifact and errors can occur if patient has any osteomalacia. Specifically in our group, the adult spinal deformity, some of the pictures that we note here is when you do the DEXA scans on the lumbar spine, for patients that have any curvatures, you can have an increase of sclerosis depending on the side of the curvature, which can throw off the T-scores and falsely elevate such. And so that's one of the things that can be artifact and errors. And then you also have technical errors that can take place with technicians. Although one paper that they cited was that there was high inter-rater and intra-rater reliability of doing DEXA scans on the forearms in these patients to detect osteoporosis. And so the sensitivity of such would be 88% and specificity of 62%, which the paper did note. Again, this is just another representative image of some uses of the DEXA scan in the forearm versus just the hip alone, and so some of the scanning issues. And then one thing to note, in very obese patients, doing the DEXA scans in the forearm could be preferable or highly recommended, because then you can detect the osteoporosis and such and avoid some of these hip scanning errors in these populations. So concluding slide is, again, DEXA scans in forearm and the hip are highly valuable. And so for patients that you are working up for any spinal instrumentation and adult spinal deformity, it would be highly recommended to get the scan done in these patients. So I would open up the floor for any further discussion.
So that was excellent, and just out of respect for you, I'm gonna just wear a mask right now. Let's ask maybe Dr. Heyman to come up and present his case.
Okay.
And then keeping 6 feet and alternating, the two of you can answer questions if that's all right with our Texas colleagues. So Eric?
Okay. My name's Eric Heyman. I'm one of the fellows here at Swedish. I came from the University of Maryland where I finished my neurosurgery residency. So today is a case that's related to the issue of bone density and an illustration of why this matters, especially in deformity correction. The patient is a 58-year-old female who represented to our clinic after a relatively urgent deformity correction. The patient had initially presented to Dr. Chapman's clinic in spring of last year. Why is this not going forward? Spring of last year, with worsening gait and hand difficulties, as well as progression of a deformity, a chin-on-chest deformity. She had previously had a cervical laminectomy for a similar condition, myelopathy. But despite the surgery, her symptoms had continued to worse. She underwent a successful correction of deformity and was lost to follow-up, and initially did well, but in the winter of last year, represented with worsening back pain and increasing difficulty ambulating. These films on the left and right are actually her original films prior to her initial surgery at our institution. At that time, she was quite weak, quite myelopathic, with significant hyperreflexia. She improved after that surgery, but when she represented to our clinic, she had progressive lower extremity weakness. Pictured on the left and right are her original films prior to her initial surgery, her initial deformity correction, demonstrating significant cervical kyphosis and some early head drop, as well as compression of her cord over the kyphus despite the laminectomy defect. This shows the results of her initial surgery. As you can see, it's an excellent deformity correction. Because of her bone quality and history of multiple compression fractures, the fusion was actually extended below the area of fractures to the T7 level, and both the T7, the lowest instrumented vertebral level, and the level below that were prophylactically cemented in anticipation of possible compression fractures given her poor bone density. Despite this, she developed evidence of distal junctional kyphosis when she represented to clinic this winter with evidence of cord compression. And you can see she actually broke down between the lowest instrumented level and the level below, despite all the prophylactic measures taken during her initial surgery. Why she failed so readily is probably multifactorial. She's not the healthiest patient. She has a history of significant opiate and nicotine abuse, and because her surgery was done in a relatively urgent fashion the initial time, she did not have time to be optimized with Forteo or other agents. But this is a case where bone mineral density was rather helpful, just because it allowed for sort of urgent assessment of her bone quality, which it's not pulling up.
It's not going.
It's not going. Let me see if I can do it up here. Okay, just skip it. Okay.
Skip it.
Yep.
Wake up.
Second wake up, actually. I generally set 2 alarms. So the patient, as a result of this distal junctional failure, The patient was taken to the OR for extension infusion down to L1, essentially incorporating the entire thoracic spine to the construct. And this belt and suspenders type approach was used to prevent DJK in her the second time around. Other than good quality, large screws at the lowest level, the patient also went to prophylactic cement placement at both the LIV and the LIV+1. In addition to this, the tension band was supplemented with merceline tape wound around the levels below the area of instrumentation, which were then tied to construct to act as a sort of modulator of the stresses at the lower levels. In other words, rather having a large stiff segment next to an unprotected segment, the tension band tape was thought to act to decrease the force experienced by these levels to add a more gradual transition. Incidentally, the patient also had some L3 force stenosis, and given that this had been exposed for the purpose of tape placement, a Coflex was placed as well at the time of surgery. The patient did quite well. As you can see, she had an excellent deformity correction and was actually discharged with less than a week after the surgery. Just in terms of teaching points, DJK is a major problem in cervical deformity correction, but especially in patients where you don't have time to optimize. From a technical perspective, although it seems like a lot of surgery, Dr. Chapman, would you have stopped at L1 the first time, or perhaps?
We'll talk about that in a second.
Perfect. And then, yeah.
Yeah, stay up here, stay up here. So, but we'll keep 6 foot distance. So excellent things. Well, I'll ask Dr. Pierre to come up. Texas, are there any questions, comments? So we have a scientific article about the DEXA scan, which is touted as the gold standard. And I'm not even sure that qualifies as silver standard. It looks more like bronze, a shaky bronze, a shallow bronze coating standard to me, with a sensitivity of the mid-80s and a specificity in the 60s. Per your article, and frequently misread because of wrong sampling. And in Eric's case, we had a patient who we actually did a DEXA scan on. She was around 2.5, minus 2.5. For insurance reasons, a variety of factors and time factors, we could not really implement expensive medications. So any thoughts from Texas whilst I hold off on talking?
How available are forearm DEXA scans? Because we don't see that as part of our routine scanning. And you kind of answered the second question. You know, how would it have helped you? Would you have done anything different? You already knew the patient had bad osteoporosis, but you were sort of stuck with doing what you did. So even if we could find the ideal diagnostic test, we can't. It seems like we can't always use it for better therapeutics.
Great points. I'm going to ask Cliff to answer that, but as I understand your question, should we get a forearm scan routinely in spine patients rather than a spine scan? And how does it actually... Go ahead. And how does it help us preempt?
So again, based off the article, they said it can be variable. In this patient population, they highly recommend doing it because they saw that it would add clinical values, especially including it with the hip scans. In the lumbar spine for adult spinal deformities, there are a lot of variable factors just due to local structural changes that can falsely elevate the T-scores and misdiagnose osteoporosis in these patients. And so I don't know if it's something as when we put our orders in, can we specify location, but it is something that we can discuss with the radiologists and those running the scans, and to add a forearm, maybe include that in the comments, include a forearm, especially for our adult spinal deformity patients.
Eric, you've been on my service. We routinely order forearm, or actually a wrist and hips. Maybe you and Cliff can talk about, should we do the wrist or the forearm? And did you see us actually ever ordering anything in the spine for DEXA scans?
Generally, no, although doing spine, I think, would be difficult in our patient population since most of them have prior instrumentation or severe deformities, which would make spine DEXA challenging, technically challenging. One thing which is fairly common, I think, which we'll discuss later, the video was depicting what I've come to see as a fairly robust method for measuring bone density in the spine using CTs, which I think is the focus of the next journal article.
So any other questions from Texas? Otherwise, we'll go to section 2.
Jens,
Yes.
we see tremendous variability in the bone density scans in Dallas. Most of the time, hip and the spine, what we do, we look at the plain x-rays and make a determination whether or not the levels we're seeing are falsely elevated. And granted, with deformity, and they showed, you fellow showed the one picture where you had disclorosis, you have to take that into account. But rarely do we see them doing the wrist. So everybody has a different technique scan. The advantage of the DEXA, however, is that there's a tremendous normative data. I mean, there are literally hundreds of thousands, if not millions of patients now that have had the DEXA scan. And I know we're going to talk about the QT scanning, which I think will be the technique of the future, but we don't have nearly the normative data.
Excellent point, Rick. So this is a real issue. And what Cliff again highlighted was that between each DEXA scanning unit, there's actually a difference of about 10% or so. Yeah. So DEXA is not really a very concise measurement tool, although we have a huge volume of data. Each scanning site is different from the next in terms of even the same manufacturer. For instance, Hologic, they have no consistency because it's a subjective test still in terms of how the tech does it. And the scanning acquisition is actually also not completely standardized. So each scanner has a roughly 10% error of magnitude. Fair? Fair. So great point. So yeah.
One other comment, Jens, Sizzy Lieberman. The case that you had presented there, I didn't see full-length standing x-rays. And maybe one of the issues that we should be highlighting is, along with bone mineral density, looking at overall spinal balance and adjusting where you're going to start and stop on the basis of the spinal balance to ensure that you don't have a fulcrum right at an apex or at a junction in the spine where your instrumentation or your prophylactic augmentation may be.
I could not agree more. And again, in said patient, I made a decision to stop just below the apex of the kyphosis, but obviously that was still too much to bear for her, but a great point. May I suggest, because your point will apply to case number 2, that we proceed with the second section and then revisit what you said, Izzy. Is that okay?
Absolutely.
Okay, I'll introduce Dr. Ben Schell here. He's a Texan from UT Southwestern. Really pleased to have him here in the Pacific Northwest, where the great Seattle freeze is now flattening the curve.
That's right.
Dr. Schell.
Like Dr. Chapman said, I'm Ben Schell. I'm one of the spine fellows here. I did residency at UT Southwestern down the road from you guys, so I hope everybody's staying safe there in Texas, and you guys are trudging along like we are, trying to get as much work done as you can. So this is the second case we actually just did recently. Here we go, that's showing up. Acute disjunctional kyphosis, so we'll try to make this quick. Complicated social history for this lady, but 64-year-old female that we originally saw back in clinic in early February, had this progressive, and I'll show the films here on the next slide, but the progressive chin on chest deformity over the prior 6 months. She had the subsequent torticollis where she was trying to maintain her horizontal gaze because she had such a significant clinical chin on chest deformity that she was twisting her head to try to maintain that gaze and still be able to ambulate. As a result, she had some gait imbalance, swallowing difficulty. She had some lower extremity weakness, which you can kind of see from our exam. And then some hyperreflexia as well. She used a cane for ambulation. And then the kind of significant social history that we teased out a little bit more as we went along through this is that she's a recovering alcoholic since August of 2019 with some intermittent lapses that we have since found out. And then she quit smoking back in 2012. So here are her original screenshots from the CT. There's a little bit of a video right there in the bottom right showing that torticollis. and that axial rotation that you'll see there in a second. It'll show it as well in the coronal. And then you can see the significant chronic compression of her upper C-spine as well in the upper left. And then we'll touch base kind of as the theme for today on her Hounsfield units, which we will see here on the next slide. Because we were debating, as we often do, on where to stop on these patients. She was originally indicated for a front back neck surgery, and then the question becomes, where do we stop? C2 to T2 is a common procedure, and then oftentimes, we can go down to C3, C4, and in her case, those vertebrae down there at the bottom, that's T1, T2, and T3. So if you specifically look at the Hounsfield units, and then the axial is T3 as well. Specifically look at the Hounsfield units, cutoff commonly used in the literature and that we use here is 100. And so regardless of where we had stopped, 1, 2, or 3, we're over that 100 benchmark as clinically indicated. And again, this is another patient where due to her gait imbalance, due to the significant torticollis, due to her acute decompensation, was someone that we did not exactly have a lot of time to optimize her with any adjuvant therapies. So she underwent an uneventful C2 to T2 front back neck. Excuse me. I'm sorry, yeah, C2 to T3 front back neck, all in one day, no issues intraoperatively with cortical purchase, no issues with overt clinical signs of bone density. We preserved down here in the bottom right on the AP, we preserved the midline posterior ligamentous complex as we dissected out the pedicles for the thoracic screws. We didn't see anything to indicate any soft tissue compromise. We weren't worried at the time. This is her immediate post-op CT showing restoration of the alignment, good purchase of all the screws, adequate alignment of the anterior neck spacers. And again, no problems there. She was discharged actually surprisingly quickly. Due to the kind of the backlog in the hospital, this was at the very start of the COVID pandemic over in China, and we hadn't shut down things here yet. And so there was a little bit of a backlog on the floor. She was actually almost discharged from the ICU. We routinely send these patients to one-night stay in the ICU for airway monitoring, and she was almost discharged from the ICU on day 2 because she was doing so well with therapy, hand motion, swallowing had returned, and so she actually did really, really well post-operatively. But then, kind of fast forward, post-op day 27, so it hadn't even been a full month, she came back to our ED with severe neck pain, posterior neck pain, and concerns that her oral medications weren't controlling it. She hadn't had any falls, no trauma. She denied any use of any substances, no alcohol, no increasing drug use, nothing like that. And she had presented with these films where she'd had an acute distal junctional kyphosis. We had not braced her. We thought we had gotten good purchase, all of our screws. We had not put her in any kind of orthosis. And she presented like this on post-op day 27. So to remeasure those numbers, so the screws stop at T3, unable to get a T4 measurement because of the screws digging into the body there. But at 5 and 6, again, the Hounsfield units, in the 120s. So it's really unclear on where we could have stopped. We didn't want to stop in that apex of the deformity. We thought we had overcome her biology on this one, but again, she was somebody that we had to revise rather acutely, and we actually did this last Saturday. And so similar operative plan that Dr. Heyman just presented, where we extended the fusion down, and we went from T3, which was her original site, stopping all the way down to L1 with screws. And then we augmented L1 and L2 with the cement, which you can see there distally. And then in order to get her alignment back up between T3 and T4, there are bilateral globus rise cages where we were able to expand those cages up and kind of restore some of her native alignment. And then these are her standing films now. And so we all also, it's not able to see on the x-ray, but we also did the same banding technique where we attached it to this cross link right here where we took the Merceling tape, placed it around the L2 spinous process, the L3 spinous process, the L2 spinous process, and then wrapped it up so that it ties onto that crosslink. We tie it tight to the crosslink. We loosen the crosslink attachments to the rods themselves and then slide the whole thing cranially. And so we make sure that it's taut and then lock it back down to the rods themselves. Again, she's done really well postoperatively. She's still in house. Hopefully she'll go home today or tomorrow. We just did this Saturday, but no issues during the surgery. So hopefully this will be someone that we can, do well postoperatively. But again, it just kind of goes back to the overarching question of where to stop, how far to go.
So thank you, Ben. Stay up front here. And this is a case to show, again, how we use something called quantitative CT scans now as a screening tool rather than DEXA scans, which take a while and have a kind of a diffuse thing. And next is Dr. Ryan Goodmanson to discuss critically how this kind of a CT screening using ROI circles with Hounsfield units may or may not actually work. So Ryan. And then stay up here, Ben.
All right, I'm Ryan Goodmanson, one of the orthospine fellows here as well. And we have, 1,000 windows open.
Looks like my desktop.
I have no idea. No, here it is. So this is a review paper that was done out of Loma Linda in 2018, and we'll kind of jump around because it is a review paper. There are a lot of other papers that we can kind of discuss in there. We'll focus in on a couple of them, just talking about basically measurement techniques and the utility of these Hounsfield units for the assessment of the quality prior to spinal instrumentation. So basically, as an introduction, we need to assess the bone quality. Everyone knows this. DEXA scans, like we talked about, have been the gold standard, but are they the best thing? They can have falsely elevated measurements in compression fractures, vascular calcifications, or degenerative disease where there's a high amount of sclerosis. And so what's another way to measure? People have been looking at now something called a Hounsfield unit, which is something we can measure preoperatively on a CT scan. This particular article was a literature review of Medline and Concrete Library as well as Embase to look at studies related to Hounsfield units and bone mineral density. The technique they used or looked at was one described by Schreiber back in 2011, and the studies mostly followed this model. And how this model went was a PAC system is used to basically measure what is called a region of interest on cancellous bone within the vertebral body. The measurement is as shown in this on the right-hand picture there, where you measure just inferior to the superior end plate of the mid-vertebral body and just superior to the inferior end plate on axial cuts in vertebral bodies of interest. He measured in L1, and most of the studies measure in L1, but some other ones measured L4 and L5 as well. These measurement techniques have been pretty much validated across several different studies. Schreiber himself saw no difference in the Hounsfield units between one slice technique and a mean from 3 axial slices. Ram looked at the size of the ROI circle and found that circles of 50, 100, and 200 millimeters squared, there was no difference between those. And then Butoff, and we'll talk about this a little bit more, Butoff looked at phantomless versus phantom-based quantitative CTs and found that they correlated very well as well. In this particular study, they looked at results from several different papers, and something that we're going to focus on, again, kind of with this case is the adjacent segment fracture. So this was a paper done out of HSS in 2012, I believe. It was a retrospective case control study with patients who had adjacent segment fracture after spine fusion. They were matched patients and had a follow-up about 6 months. They did exclude patients with metabolic bone disease, those taking medications known to cause decreased bone strength like long-term corticosteroids. They measured Hounsfield units in fracture group versus their control group. And out of their 400 fusions, they ended up with about 20 patients that they were able to match for levels, age, sex, et cetera. They did find significance, though, between these Hounsfield units in the fracture group versus the non-fracture group. The Hounsfield units within the fracture group were about 145.6 as a mean, and the control group were 199.4, so a significant difference in between these two. They also saw that the global Hounsfield units across the board were less in the fracture group than they were in the control group. Specifically in T12, you can see, if I can put a pointer up here, in T12, it's hard to tell between T12 and L1, but T12 was actually the lowest that they saw across the board. The mean time to fracture after index surgery was about 14.2 weeks in their patients, and after the index procedure, they did evaluate sagittal balance, but really didn't see a significant difference, just a slight difference between the fracture and control groups in 10.7 versus 9.1. There were some limitations to this study. They didn't have the DEXA for comparison in these patients. They didn't have vitamin D levels, they said, which we all know is highly correlated with osteoporosis, osteopenia, and the study power, although matched, is fairly low. But, so what are the acceptable Hounsfield units and ranges for spinal fusions? If we go back to the Schreiber article, he did quite a bit of work with Hounsfield units, DEXA scan, and looking at it across the board. If we look at the different ages, you can see here, and I'm sorry if this doesn't project, but you can see that he looked across the ages, and if our patient was 64 that we just looked at, her mean was somewhere around, or would be around maybe 105, but the standard deviation for that is plus or minus 35, which is fairly significant. Because when you look at Hounsfield units compared to T-scores, normal, Schreiber found to be somewhere around 133. Again, a fairly large standard deviation. Osteopenic was somewhere around 100, and osteoporotic was somewhere around 78.5, but you can see the standard deviations, again, there are fairly large and actually can put you either in or out of one group. He did show, though, that there was correlation between the Hounsfield units and the DEXA scan, and that a lower Hounsfield unit did, in fact, correlate with a lower DEXA scan. When going back to the review article, then, we talk about things like looking at the pedicle screw loosening, potential for fractures, and looking at what are the units then that we are going to use to potentially avert catastrophe. Breedrow looked at the mean Hounsfield units in patients with osteoporotic fractures and looking at screw augmentation. He found the mean to be 116, but they suggested a cutoff of 120 to use for screw augmentation. And then Schweiger in 2014 looked at the risk of vertebral compression fractures and found that at 85, you were at extremely high risk of vertebral compression fractures, and at 117, you were at a high risk of screw pullout. So the conclusion from their article these authors made was basically to measure Hounsfield units in everybody, because it's an easy thing to do, and it doesn't take a new study to do, because most of the time we're getting CTs in these patients. The highest specificity threshold for detecting osteoporosis was somewhere around 110, actually, and 135 for osteopenia. They also suggested that in adjacent segment fractures and to prevent pseudoarthrosis, that anything below 150 can lead to this even higher. Something I thought was interesting about this article, and maybe a future application, is, I don't want to give away too much, but maybe AI. Can AI measure these things for us globally and look at them more closely? But to have these, like we talked about, have a greater pool of data to pull from so that we know what the correct numbers are.
Great, so good job. So Dr. Benchell and Ryan Goodmanson are here, and we'll have also Eric standing by to show how we measured it. A couple of great questions. Let's start with Dr. Michael Heisey. He had two questions. One was, Ben, you showed CT circles going through a vertebra that looked like it had a hemangioma. Does not affect the results. Can you answer that?
I would definitely think it affects the results. I mean, the way the scans, like on the articles that we've just reviewed, they're that defined area. It's that defined measurement, and it's taking an average in that circle. And so if even just a small portion of that circle is not adequate bone, then yes, it's going to definitively throw that measurement off.
So maybe a quick live presentation on how he calculates HU units to avoid an artificially low thing can be quickly demonstrated by Dr. Eric Heyman again.
Certainly. Just let me pull this up.
On the same realm, if you go the other direction and get too much cortical bone, rather than cancellous bone, it'll throw it off and make it too high. So if you measure too much or too little of the right thing.
Can you just stand on the side a little bit? Take a plastic model and answer another question. How does the distal banding technique of Shaffrey work? So can you just stand a little bit on the side, Eric, whilst you're trying to?
Yeah, it's
Does it work now?
it's parts.
Is it working?
Yes.
Okay, then take it.
Okay. So discussed previously, you can do this either through axials or sagittal slices, but the key is you need a clean slice, like that was mentioned previously. You can't have hardware hemangiomas or even, abnormally corticated bone. So essentially, the target here is the cancellous bone in the middle of the vertebra. It's depicted here. You want to avoid pedicle. You want to avoid the cortical wall of the vertebra. You want to avoid any weird disc spaces or, that might be slice artifact. So what you do is you take these ROI circles, which are just draw a circle and collect an average of the Hounsfield units within this region of interest. And you want to create a sizable enough circle to get a good sample space, but not so large that you accidentally grab a little bit of the cortical surface like I just showed. In this particular vertebra, derived from the patient in the first case, Hounsfield units were about 125 at that level, the LIV +2. And then measuring in a separate slice, again, try and find a good clean slice with just pure cancellous bone. The RIs, again, were consisted with 110. So osteoporotic, certainly not an optimal candidate for a fusion, although unfortunately her overall medical condition necessitated urgent measures. So.
Yeah, can I just
Please.
comment? First off, you should try, I think, to use the coronal and sagittal CT scans when you're measuring the Hounsfield units. The reconstructions, I think, are going to give you a more uniform view of what's going on in the vertebral body. From a biomechanical perspective, we know the failure is the anterior cortex. So taking one transverse slice is not really telling you what's going on from superior end plate to inferior end plate. And if you're using your sagittal and coronal reconstructions, you can actually cheat your Hounsfield unit measures to the anterior cortex without including the anterior cortex and see what's going on at those levels. The second thing is when we're talking about fusion, and I've heard this a couple times, so a couple of the speakers mentioned that the Hounsfield units are correlating with pseudarthrosis. It's correlating with osteoporosis. We know that osteoporotic bone still fuses. It's not a good fusion, but it still fuses. So let's not make that misnomer that osteoporosis causes pseudarthrosis. The third thing that I wanted to mention was the pedicles. And this goes right back to work that we were doing 15 and 20 years ago, trying to optimize fill within the pedicle with the pedicle screws. Because maybe what we need to do is rely more on pedicle purchase rather than the vertebral body purchase, or look at complete anterior cortex, middle, and pedicle purchase. So actually going through the anterior cortex with it to gain as one of the reinforcing maneuvers that we can use to get these going.
Great points. And again, one question, Izzy was just still on the microphone there. One of the questions that I got was cementing screws. Can you address cementing screws? So you talked about bicortical screws. Please address cementing screws, and can you combine cementing screws with bicortical screws? Thank you.
So as I approach these cases, every case I go into, I always plan to be instrumenting one or two more levels, more cephalad than I would have to. Most of these are going into the pelvis regardless, but I always leave myself that leeway so that if I am uncomfortable with the purchase, I can grab another level up or down, and being wary of the junctions, the cervical thoracic junction and the thoracolumbar junction. Augmenting the screws, I'm very liberal at augmenting screws. It depends on the type of screw that you're using, but clearly if you're using one of the fenestrated screws, you're not going to be able to use bicortical purchase with that screw. So what I will do is augment my last instrumented vertebrae with a screw that's still well contained within the vertebral body, augment the level above, and then strategically augment levels below that I may be concerned with. So I don't necessarily augment every screw in the construct, but I try to figure out where the biomechanics are going to be challenged and augment those screws. I've been really pleased with the technology that's out there with fenestrated screws. I think that's made our life very, very easy when it comes to augmenting these screws. Traditionally, we would have to put the screws in, take the screws out, fill the bone with cement, and then try to get the screw back into the right spot before the cement cures. And I'm not ashamed to say I've had a couple screws that we couldn't get in fast enough and ended up being very proud. So it really made life difficult with cross connectors and everything else. So those are some of the strategies.
Great. Thank you. So there are two more questions. Rod, do you want to read those out?
Dr. Boa was asking, any thoughts on cement augmentation?
Yeah, I think we just...
First time around.
Yeah, so cement augmentation first time around. So again, I sound self-defensive. We did augment the distal end, which is Dr. Lieberman's focal point of failure. We did augment the distal LIV segment and the LIV -1 segment, and it still failed. And the second thing was the ligament failure, so thanks.
And then Dr. Satine asked, any thought for use for Teo Postop for urgent surgeries?
Great question. So for Teo Postop, now we have honestly not done that. We have a great mineral metabolism colleague, but we've never really done that post-op. We've tried to do it like 3 months before surgery. In one of our patients, we would have not had insurance coverage for it. And the other one, that would have been a definite option possibly. We could have probably gotten insurance coverage. So great question. We'll have to reinvestigate that. Quickly, Ben, maybe using a pen, show us the distal banding technique on a plastic model. We did not prepare a slide, unfortunately, but assume that using one finger as your distal fixation, how do you distal banding? That was another question.
Sure. I don't know how well we'll be able to see this on one of the cameras, so try to rotate. There we go. So, we went down to L1, so 5, 4, 3, 2, 1 with screws. So we stopped here with screws, put cement in at 2, and so you take the Merceline tape, you leave the PLC intact, you poke through a hole with, hemostat or a 90-degree poke through, stick the Merceline tape through. It's got a metal, kind of a blunt tip on each end. You feed it through while keeping the PLC intact, feed it through, and then come them out each side evenly, and then you cross them around the SP, and then again, bring it through again, tighten, cross it around the SP, and then bring it through a third time. And so up here, we've taken down the SPs, laminectomy or not, and the rods are running each side. And so you can affix it to the crosslink right here, tighten it first, tighten it down as hard as you can. Dr. Heyman said I had the pleasure of tightening it. It was a very difficult thing to do. And then once it's tight to the crosslink itself, you subsequently use a distractor like you would for a deformity correction on the pedicle screw and then on the crosslink itself, and then you push them out. And so you can kind of see that what that would do is that would appropriately tension these structures into some lordosis, and it would give you an additional tension banding technique. Where is that? Oh, here you go. Too much. That would give you that additional tension banding technique kind of as an additional structural support there to prevent that acute DJK that we had.
Hopefully prevent. Ben,
Hopefully prevent.
look at this autograph. Can you highlight this autograph of the robot camera? Yeah. Do you know whose autograph that is? It says, "To my friends." Izzy, do you recognize that autograph? That's Jean Dubuisset. This has been held by greatness. All right.
So one more question, actually, it's, let me pull it up here. So the final question that we have is, what was the sagittal alignment before the case? And can you show the x-rays?
I can't right now because of time, but on the second case, to a flaw, we did not have full-length sagittal films. She was a relatively acute deterioration, a neuric 3, heading worse with the chin on side. So I acknowledge the problems you saw in the final images, that she has lumbar degenerative scoliosis. So I assume that over time she'll become a fusion to the pelvis. And one question we can maybe table until Bilal is done with his part is, how much surgery can we do for a patient in the first time around when they have a pretty acute problem? Should we just go to the pelvis right away and compromise patients? So Bilal is going to talk about quantitative CT, and then we have, if we give us time, one more clinical presentation.
Good morning. My name is Dr. Bilal Kutina from Jerusalem. I did my orthopedic residency in Hadassah Hospital in Israel. I will talk about quantitative CT. It was first introduced in the mid-1970s at UCSF. About the technique, the patient underwent CT, and when he underwent the CT, he do it with phantoms. These phantoms, we use them for calibration to convert the Hounsfield units to bone mineral density using a software. And one of the phantoms is the calcium hydroxyapatite. And according to the results, if we have bone mineral density 80 to 120, it is low bone mass osteopenia. And if it is less than 80, it is osteoporosis. Okay. Okay, about the positive of this technique, it is high accurate in determining tissue density. It allows us to assess the cortical and the trabecular portion for bone mineral density, which is not found in the DEXA scan. And also 3D volumetric bone mineral density. And it is more sensitive to changes in comparison with DEXA scan, because as I said, it allows us to measure the trabecular bone mineral density, which is the portion of the bone which is more metabolically active, and it is more sensitive to ionization. And it can be performed on the commercially available CT scanners, provided the phantoms and the software. Regarding the negatives, it is still a CT scan, so it is higher radiation dose than the DEXA scan. And about the cost, that we don't get reimbursement, and it is more expensive than the DEXA scan, and it takes time to have the results. This is from the ACR appropriateness criteria in patient for screening of osteoporosis. Still, DEXA scan is the gold standard. Quantitative CT for the lumbar spine and the hip have high radiation dose. And in patients with low bone mineral density, for follow-up, we use the DEXA scan. Also, we can use the quantitative CT scan, but also the problem is the high radiation dose. Because we do fine cuts of CT, one of the thoughts to have low dose radiation and also to do cuts for L1, L2 only. Indication for quantitative CT, it is the same indication as the DEXA scan, and if the DEXA scan is not available, we can use this technique. Specific cases that the quantitative CT is superior to DEXA scan when we have extremes in body height. As said previously, the DEXA scan is size dependent. in severely obese patients, patients with extensive degenerative disease of the spine because of the artifacts from sclerosis, osteophytes, and in a clinical scenario that requires increased sensitivity to small changes in the trabecular bone density, such as a patient receiving steroid or parathyroid hormone treatment. And because of the radiation dose, this technique is less used now. It is a very powerful research tool, which allow us to assess the trabecular bone mineral density and the cortical. And thank you very much.
Great. So stay up here. Maybe Lincoln can come up also. So turning it back to Texas, so any thoughts on quantitative CT? Is this the way to go? You heard from Bilal. It's a tremendously high radiation dose because we have to do fine cut CTs. But since you have robots like Izzy's using his Mazor, this is maybe the new norm, and we just have to radiate our patients. We also have to wait for it, and this is an unreimbursed function. Currently, it's about $250, and we have to wait for about a week to get this analyzed. So you guys are a little bit ahead of us sometimes in tech. What is your view on that? I think Rick Geyer was talking about it earlier, and Izzy.
We tried the quantitative CT when we were screening patients for disc replacement. And the problem is that there were very few radiology facilities that would do it. I assume your hospital is doing it routinely for you guys. The other thing, in the article, they talked about the 3D quantitative CT. And I think that once that is perfected and once every radiology suite can do the same procedure, it'll be much more accurate than the DEXA. The real problem is, unless it's a deformity case, it's hard for us to justify all the radiation if we're not going to do a CT, say we're doing a disc replacement. Clearly, the scan has been the main thing we've relied on for disc replacement rather than the CT. In some cases where they're borderline, we have got the quantitative CT, but I personally have not been impressed with the reproducibility of the results. But I think it will be the state of the art.
Izzy, since you have to get really good mapping studies for your deformity cases for robotics, should we just always add a quantitative or 3D quantitative CT to our imaging?
Never say never, never say always in medicine. We are doing them routinely for our deformity cases. I do get that information because we are doing 1 millimeter fine cuts for the mapping CT scans. So for us, it becomes a natural, and we're not really over radiating the patient in the grand scheme of things because we're saving radiation in the operating room by not using intraoperative CT scans or all the intraoperative x-rays. Now, the one point that I do want to make, and don't misinterpret this, I absolutely agree we have to be conscious about radiation. But look at our patient population right now. These individuals that we're treating are 60 years old and up predominantly. If they get a radiation-induced cancer, it's going to take 10 to 15 years for that to really affect them. So I'm not sure it's as much of a concern in the population that we are dealing with. Now, exactly what Rick said about disc replacement and others, absolutely. There are other modalities that should be used to do that. And in our pediatric patients, we have to make sure that we are very, very, very conscious of the radiation dose.
Since you're on the microphone, Izzy, alignment has been mentioned by several questions, and you mentioned that also rightfully. In the first case, I went down to T7 and augmented T8. But talk about the magnitude of surgery and trying to rebalance the spine versus a more limited fusion with best possible realignment. Because again, in all these cases, you could make an argument to just go to the pelvis right away, but that would overwhelm these patients with an already 6 to 8 hour surgery, wouldn't it?
So up until the current situation, the biggest problem in my life has been where to start and stop. Now the biggest problem with what we're dealing with in coronavirus is who we're going to actually operate on these days. But yeah, I don't know the answer to that. Every morning I wake up, I look at the case list and I say, am I stopping at the right spot, at the wrong spot? And I just default to global alignment and balance, get the head over the pelvis, and I draw my sagittal vertical axis, and I try to make sure that my instrumentation is going to get the spine into that plane, into Harrington's stable zone in the coronal plane and to the appropriate sagittal balance plane. And if I can do that, sometimes I win, but sometimes they still fall apart, even with our best efforts.
Talking about falling apart, I know it's 9 o'clock for you, and some of us have to go to the OR, myself included, in about 20 minutes. Would you in Texas be interested in looking at one more case presented by Lincoln Jimenez that shows rebalancing and failure points by myself, or would you want to adjourn?
Let's see the case. I need something to make me smile.
Absolutely. Go.
Okay, so Lincoln Jimenez is going to come up and show a final concluding case, and then maybe Rod can lead a discussion on final thoughts. But starting, where to start, where to stop is a really big deal, and I have the same awake daydreams and night dreams that Izzy has with safe harbors for fusions. Dr. Jimenez.
Good morning, my name is Lincoln Jimenez. I'm one of the spine fellows here at Swedish. And I'm going to present a case pretty much in the same line of what Dr. Chapman was talking about, which is where to stop in certain cases. We have a case of a 73-year-old female with history of chronic low back pain. Fortunately, she also had polyarthropathy with multiple cervical and lumbar thoracic surgeries that occurred between 2016 and 2017, as well as a knee replacement. She had also, by us, did have a surgery in February of 2017, revision and decompression and fusion from T3 to T10. Significant medical history includes diabetes, obesity, GERD, and arthritis that was using prednisone. Unfortunately, because of the COVID situation, the patient, we have not been able to evaluate her properly, meaning in person. So we did a tele-physical examination, which showed difficulty in putting the fingers between her chin and chest. No malformation and difficulties in moving small fingers as well as grasping. The ambulation was quite wobbly, and she had a DEXA scan, which was actually a remote DEXA scan from 2016, that revealed that there was no issues regarding in terms of osteoporosis or osteopenia. Along with that, that DEXA scan was compared to one from 2008. So regarding her images, we have a patient with significant scoliosis. And as I said before, she had in 2016, a cervical fusion, and the surgeons that at that time decided to perform a lumbar spine fusion due to stenosis as well as low back pain for this patient. Later in May, the patient continued to have back pain and progressive problems to ambulate, and they extended the instrumentation up to T10 and to T9, and then they also did a L5 S1 ALIF. Later on, because they were concerned about potential failure of this instrumentation, they actually supplemented with a T8 vertebral augmentation. This was also because the patient did present already with some compression fracture at that same level. January 2019, and through all that, since her last augmentation, the patient unfortunately was developing already an increased kyphosis, thoracic kyphosis, as we see here. and back pain, as well as myelopathic changes. So for which reason, after evaluating and discussing with the patient, excuse me, excuse me, it was decided to extend the instrumentation with a soft landing at T3. In this case, what was done just extension, and there was no banding done. There was a discussion at that time in doing or extending the instrumentation up to C2, but there was also the concern that if a fall occurred, the patient may have actually gotten into trouble. So unfortunately, the patient came 3 months later, and I'm sorry, 2 months later, and she had already failed the surgery, and now, of course, she's actually having more problems to ambulate, more myelopathic changes, and the latest CT scan revealed a compression fracture that has been progressive since April last year. Nowadays, the T2 compression fracture is over 50% collapse. So the questions is, and of course we have already answered some of these questions, is, how far to extend? Excuse me, how far to extend our instrumentation? Should we be afraid of doing such approaches? And of course, what is the sensitivity in this patient? I think that to answer the last question, just because some of the other questions above are already answered, in this case, for this patient, and just based on the papers that has been discussed, the patient should have had the wrist or the forearm being evaluated by DEXA scan, just to make sure that we had understood the bone density on this patient before any surgery was offered to her. The other question, should we have extended furthermore the instrumentation up to C2, particularly in a patient that has 2 stiff segments? And the question will be is, if we tend to do that, the problem is that if the patient falls or fails again, she may have actually a larger problem with more neurological complications. I don't know if you guys have any further questions or.
So thank you, Lincoln. So Izzy, did I put a smile on your face with this perhaps predictable failure?
Yes. Again, where do we start? Where do we stop? I may have missed it in the presentation, but what was her initial presenting symptom again?
At the very beginning?
Yeah, very first symptom.
The very first thing was she had cervical radiculopathy, for which an outside surgeon performed a 4-level ACDF, which healed well. And slight kyphosis, but it did heal.
And then you came back and why did she have the lumbar procedure? Or that
was done elsewhere. A limited lumbar fusion was done elsewhere. And the second fusion for the lumbar spine was also done elsewhere, up to T9. And she then had a vertebroplasty done by one of our partners to T8. So all that was done elsewhere.
So we don't know what her initial presenting complaint is. And the point I wanted to bring up, last week or 2 weeks ago, we had our journal club where we talked about limited symptom-specific surgery in some of these deformity patients that present with a 4-5 or a 5-1 issue, and just dealing with the fractional curve instead of dealing with the whole scoliotic deformity and alignment. And again, the sentiment is still variable. No one really knows what to do. But under some of these circumstances, we may have to ignore the overall deformity and deal with the specific symptoms, being radiculopathy or focal stenosis. And in other cases, we're going to have to deal with the whole deformity. And we still don't know that. We still don't have a good enough algorithm to figure out which way to go.
So leaving here today, the big question that was raised by our fellows, and I want to thank them and acknowledge their excellent presentations, was what should we do for screening? Should we do quantitative CTs? Should we do 3D quantitative CTs? Should we do the Hounsfield units? And you're, by the way, right, Izzy, they should be done in sagittal planes rather than axial planes. Should we just hope that the DEXA scan, which is very kind of vague, is actually sufficient? Should we hope that the various metabolic, anabolic, bone-enhancing agents become more available? Very doubtful right now. I'm not sure where to leave that. So from our end, I'm going to ask Dr. Oskuyan to take the helm here and maybe conclude our discussion part with some thoughts, and then maybe you guys can repartee.
So I wanted to, since we're all in the corona mode, we actually had, it's very interesting, I don't know if you guys knew this, but we had the very first patient in the United States that actually showed up in just north of us in Everett. And I don't know if, let me see if I can just pull up a link for you guys, because it's actually online and it's free, and I thought everyone could read about it. But what's interesting is that, and I think this is a reason why, if you look at the immunology and biology of the virus, is that these little, you know, the corona molecule, it's got these attachments, and these attachments are real, and the article kind of goes over. It's a great article because it shows, it's one case, but it shows the clinical course of the patient. And fortunately, the patient actually called the hospital ahead and said, listen, I was in Wuhan. I saw this thing. It's you know, I think I might have the coronavirus. He showed up, and fortunately, the hospital staff and the people there actually were all, you know, wearing gowns, gloves, and the patient actually ended up getting very sick, did not have to get intubated, but let me just pull this up for you guys. And it's just very interesting because, you know, just to have this written up, and also the way that the symptoms of the patient presented, and also you can see what ended up happening is the patient ended up getting the experimental treatment that they're talking about, and got better. And now it's always hard to tell, but the main thing, and again, this is why it's really, you know, when you go back to cell biology, these cells, you know, that's why it doesn't, you know, people say it's the great equalizer, but the way the virus attacks is that these viral attachments go right to the respiratory system initially, and that's why the patients present the way they do. Finally, here we go. I just pulled it up. So it's free and it's online, and here's the summary. And actually, and again, it kind of talks about, and what's interesting is now when, you know, the epidemiology and the statisticians look at it, they're talking about how, you know, in China, they're saying it was only 84,000. But for the way that this virus spreads, that this patient ended up coming to Seattle, and then it kind of goes over the clinical history. It's got a very nice section on his symptoms, how he presented, and then they have some, there's some images you can see of the chest x-ray, and and it goes through the clinical course of the patient. And what's interesting too is initially the patient was, when they did their initial test, the serum was negative, but then a couple days later, they were able to do further testing, and they came back with positive tests. And it just kind of goes over the clinical course of, and the patient ended up getting some of this experimental treatment that we discussed. And again, because it's one patient, it's hard to tell whether or not the treatment actually did anything for the patient. But what's interesting to me is how quickly this patient ended up getting sick and needed oxygen, needed supportive therapy. And what's interesting is that Bill Gates talks about this, but I think this is really important, is I think there has to be a systematic approach in terms of, how to deal with outbreaks like this. And then the second thing is there has to be rapid testing so people can know, okay, I have the virus, I don't have the virus. And then the third thing, I think, which is really important, they talk about this in the article, is understanding how the cell biology and how these things spread. Because now, for example, we came in the hospital this morning and they were handing out masks to everyone. And then a week ago, 2 weeks ago, they were standing firm on, hey, if you're asymptomatic, you don't need to wear a mask. But now they're thinking, and this is exactly what happened in Wuhan, most of the transmission is occurring with people that don't have symptoms. And so anyways, I put the link up there, and then if you just Google New England Journal of Medicine novel coronavirus, it's there, it's free, and our colleagues published it, and it's a very nice read, and you kind of go over everything. So thanks, everyone. Any thoughts from Texas? Yeah, any thoughts from Texas? Jack, Scott, Izzy?
Rod and Jens and all our colleagues up in Seattle, thank you for hosting us. Please stay safe, take care, and this was very, very informative, both on the spine side and on the coronavirus side. I look forward to seeing you guys again next week, in 2 weeks, in a month, whenever we can organize this again. Thank you so much.
Yes, thank you, Rod, and everybody else.
Yeah.
Thanks for watching. Hit the subscribe button for more medical content.